So let's start with the test. Let me remind you that today we shall face a specific chapter of cardiac auscultation that, in my opinion, is becoming more and more important. That is the aortic valve disease. It's becoming more and more important, but because, as we know, degenerative aortic stenosis is becoming a more and more important clinical aspect, clinical problem, not only because there is a increased age of our patient and therefore the prevalence of aortic stenosis is dramatically increasing, but also because nowadays we have a possibility to make correction on aortic stenosis without requiring surgery. That is the chapter of TAVI, that so-called transfemoral or transcutaneous correction of the valve. Let me tell you something. In Padua, we are working a lot in this direction. We performed a TAVI, therefore, let's say a substitution of a valve without surgery. We perform one TAVI per day, each day of the week, so that the enrollment we have is about 200, 250 cases per year. And we have so far performed approximately 1,300 TAVI in the last years. So aortic stenosis is important. And that's the reason why today we shall devote time to this important chapter of cardiology. And we have two tests as usual. And I shall show you the auscultation finding first, and then some option, and then we shall see which the opinion of the people is. So this is the test number one, and let's proceed. So these are the possibility that I want to share with you that are exactly the following. So is this a mitral valve prolapse, a mitral stenosis, heart regurgitation, or I don't know? So please make your vote, and let's take 40, 60 seconds to have voted. Okay, so still some people that have not yet voted. Please make your selection. Okay, so I think that we can wait a moment, and let's go. This is the results, and we have now that the majority of people has selected aortic regurgitation, someone mitral stenosis, someone mitral valve prolapse. So let me show you the auscultation finding now, so that we can return to the test. But this is the recording, and you can see that we have a first sound, a second sound, an ejection murmur, and the diastolic murmur that does not cover all diastole. So we have systolic and diastolic, and this is a auscultatory finding of heart regurgitation. Let's listen together. So what is important in this auscultatory finding? Here it is again. So what is important and we have to consider is that this is a diastolic murmur. Of course, mitral stenosis is a disease with an auscultatory finding that is positioned in diastole, but these are two different sounds. the aortic regurgitation, as we shall see today, is a high frequency sound, while mitral stenosis is a low frequency sound. And this makes a big difference, and that is even more appreciated if we consider, as I told you before, that the diaphragm and the bell in the stethoscope have a different role in selecting high frequency and low frequency sound. So let's go to another test, and this is the next test, and uh, I show you the example first. Please pay attention. So this is a little bit difficult because, as I shall show you, this auscultatory finding contains two elements that needs to be identified. Let's go together again. Okay, so what I shall show you now is the pulling of this test, and this is the test that follows. And please make your vote. We have the following possibility: mitral regurgitation, ventricular septal defect, bicuspid aortic stenosis, and mitral valve prolapse. So these are the results. And as you can see, the majority is vote bicuspid aortic stenosis. But let's go now on the test to show what the reality and the truth is. Few seconds, and we return on the test. Here it is, and you have a first sound, ejection click, systolic murmur, second sound. So this is a bicuspid aortic stenosis, and I have to congratulate with a lot of people that has made a very good diagnosis. As before, the majority of the tests were correct, aortic regurgitation before, and bicuspid aortic stenosis, that is not a easy diagnosis now. Okay, this is the recording. You can appreciate the fact that the first sound seems to be splitted, but this is not a splitted first sound. Is just the presence immediately after the low frequency sound that is due to the closure of the mitral valve, a high frequency sound that is the ejection click that is typical of aortic stenosis, and this will be faced during the lesson today. So let me show you for the last time. Please appreciate the fact that not only we have an ejection murmur, but we have the same splitting, a click. So after the test, it's time now to start with the presentation. And the presentation today, as I told you, is on aortic stenosis. Okay, so Dr. Renner, if you agree, I'm
Yes.
ready to start with the session. So
Okay, please.
aortic stenosis, I just introduce you the fact that aortic stenosis is an emerging uh, situation for cardiologists, but also for doctors in general, especially those that take care about old patients. So this slide is a slide that summarizes hemodynamic finding and auscultatory finding. So I already presented you last week for mitral regurgitation, but let's spend a couple of minutes to remind you that in hand diastole, left atrial and left ventricular pressure are equal, with the beginning of ejection left ventricular pressure goes up, up, up until it reaches aorta pressure. And in this moment, the valve, the aortic valve, is open. And this produces here a click that usually is not heard in people with normal valve or even a stenotic valve without a bicuspid shape. So first down is because the arterial pressure are below the ventricular, and this produces the closure of the mitral valve, and the click is the opening. Then we have the ejection murmur, and this is the typical murmur of aortic stenosis. With the decrease of left ventricular pressure, the second heart sound appears because the aortic valve closure occurs. So this is a typical finding in a severe aortic stenosis. This is echocardiography. You can see here the aortic valve. The leaflets are thickened. The valve opens much less than usual. Here we have the mitral valve. There is also a calcified annulus. And here we have hypertrophy of the left ventricle that is contracting not well. So this is a typical finding of a severe aortic stenosis in, I should say, a relatively old people, because calcification of the aortic leaflets and calcification of the annulus are only due to a degenerative disease affecting older people. So this is the same valve in a short axis, and you can see that again we have calcification, especially at the commissural level. The leaflets are partially calcified, and this is again a finding of aortic stenosis. What Doppler can do is very important because we can measure the jet through the valve, and this jet is an expression of the gradient through the valve. That is an expression of the severity of the disease. Nowadays, we have different parameters that we can use for assessing the severity, but in my opinion, and this not only my opinion, the most reliable one is the velocity through the valve, just because it's easy and is the most reproducible parameter. For someone, the cut level is 4.5 meter per second as the index of severity. For someone else, it's 5 meters. So let me spend with you a few seconds on these slides and on the next one. These are two very old slides, this one and the other one, that are representative of a very important finding in aortic stenosis. In this aortic stenosis, here we have the murmur, and here we have the carotid pulse. The carotid pulse is the expression on what we can appreciate also on the radial artery. And in a patient with severe aortic stenosis, the pulse is slow and late. So in Italy, we use a term that is tardus. Tardus comes from Latin, that means late, delayed. And the increase of the pulse is late, delayed, as the murmur. So what has been observed empirically, and this is very important, is that the position of the maximum of the ejection murmur is an expression of the severity. The later, the more delayed is in diastole, is the peak of the ejection murmur, the greater is the gradient. Of course, this is not a very precise indicator, such as cardiac catheterization of Doppler, but it's something that from the clinical point of view is extremely, extremely useful. We can make a judgment, as I shall tell you during the presentation. We can make a good judgment of the severity of the stenosis according to two elements that are the second sound. Let me return here. Here it is. The second sound that is produced by the closure of the aortic valve and the peak of the murmur. If the second sound disappear, it means that the valve is calcified. If the second sound is increased in as intensity, as in this case, it means that the valve is thickened, but still with a certain degree of mobility. So the entity of the second sound, the intensity of the second sound, is an expression of the valve status. And in my experience, we have three different phases. Normal, second sound intensity, that means the valve is still good, but no murmur occurs. Secondly, we have the murmur at increased second sound intensity, and this means that the valve is becoming to be calcified, but still has a good movement. Third, we have no second sound, and this means that the valve is totally calcified. But we shall listen the sounds in a moment. So when we have a patient with aortic stenosis, again, we have to take care about using in a proper manner the stethoscope. And let me remind you that the diaphragm is ideal for high frequency sound. And in the context of aortic stenosis, everything is appreciated with diaphragm because we can appreciate the murmur, we can appreciate the second sound, low, increase in intensity, disappeared, but more than anything else, the ejection clip in case we have a bicuspid aortic valve. So let's start with the finding. And in this first case, the auscultation has been performed on area A, that is the aortic valve area. And let me remind you that this is the typical area of auscultation for aortic stenosis. Sometimes the murmur is irradiated until C. In relatively rare cases, it is very well heard also in D. We shall spend some minutes in explaining why this irradiation can occur, but is mainly due to the shape of the left ventricle, the position of the aortic valve, and the kind of distortion existing between the septum hypertrophied and the outflow tract. So this is case number one. As I've done in the previous lessons, in this case, we have the first three beats that are with murmur. This is for producing a warming, let's say, effect. So you can start to have a rhythm, then the murmur will appear. So this is the first example of aortic stenosis that I'm going to show you. And please have a look now watching the tracing. And then please, I shall repeat, but close your eyes. So this is a very typical finding. We have a murmur with maximum intensity through the end. So it means that the stenosis is important, is severe. So let's listen again. But this time, please close your eyes and let's start concentrate. So at the end of the lesson, I shall show you two murmurs close one to the other, and it will be aortic stenosis and mitral regurgitation. Both murmurs are systolic, but I want to emphasize the differences between the two murmurs, that being both systolic are absolutely different in terms of murmur quality of the sound. This is another example in which, as I told you, the murmur is very well heard not only on aortic area, but also in mesocardium and apex. This is not impossible. This is not rare, and this is, in my experience, due to the fact that in some patients um, there is a huge hypertrophy of the proximal part of the septum, interventricular septum, following aortic stenosis. There is a certain angle between the left ventricle and the aorta, and this creates a turbulence in the outflow tract that, of course, is chronologically identical to the ejection murmur through the valve, because these two findings occur in the same part of systole, and this produces an irradiation of the murmur from the aortic area to the apex, that is the mitral area. So this is a very good example of aortic stenosis, and you will hear, I'm sure, very well all the findings. This is what we hear in an old patient with a degenerative aortic valve with maximum intensity of the murmur on the aortic area. So this is a classical finding in a degenerative aortic stenosis of an old patient. But as I told you before, there is another possibility. The possibility,
we still have the issues of the short ED, but
Dr. Reina, we have a question, perhaps?
No, I think somebody opened the mute. Okay, please continue.
And since, as I told you many times, this is a friendly interaction, feel free to interrupt in whatever you want. Or when there is, in your opinion, an important question that needs an immediate response. So let's speak about the bicuspid aortic valve. As I told you before, the bicuspid aortic valve, that is a relatively common congenital disorder, produce not only the murmur, that is the expression of the gradient, but also the so-called ejection click. And ejection click is due to the fact that this valve that is not calcified, but still is stenotic, when opens, creates a snap, a sound that is the effect of this sudden tension of the leaflet. Here we have on your right, please see your right, the leaflets that are 2 instead of 3. When the valve is open, the leaflet are 2. When it's closed, it seems that there are 3, but it's not 3. This is a rough, you have always to see in opening, there are only 2 leaflets. Let me see, here it is. We have 1 leaflet and the other leaflet. But if we go on the short axis, let me show you this opening that is not complete of the anterior valve. And if we stop the sequence, you can see that this valve is not perfectly open, this leaflet, but this curve is termed dome shaped, like a dome. So this strange opening produce the click. And here we have another nice example. Here we have the opening that is not complete, is not an example. Here you can appreciate. We have a tridimensional, and this is the ejection murmur. So let's observe now an example of aortic stenosis in a bicuspid aortic valve. Let me tell you that when we have a patient with 55, 50 years and aortic stenosis, isolated aortic stenosis, of course, is extremely rare, if not impossible, that this could be the results of a degenerative disease. more likely is the effect of a bicuspid aortic valve, especially if there is no disease of the mitral valve, which, if present, could be the overall result of rheumatic valve disorder. So in this case, we shall appreciate sounds coming from A and C, because usually the aortic murmur is better heard on A, while the click is not heard here, but is much better heard on C using the diaphragm. So the example here is, as usual, is a step by step. The first 4 cycles, 1, 2, 3, and 4, are normal. Then the click appears here, here, and then the murmur will appear. So this is a very elegant electronic modality to show you what is impossible to find in a clinical environment, because this selection can be done only electronically. But what I want to emphasize is that this is the first sound, this is the first sound, this is the first sound, and as you can see, the intensity is low, but when the click will appear, there is high frequency sound. So let's go together. First, watch the tracing, and then we shall hear without watching. So I think that is very useful example. Is a, I should say, a very explanatory. But now I want to show you the same example, suggesting to you to have your eyes closed. So please pay attention. Clear. This is another example of bicuspid aortic stenosis. This is immediately the recording of the auscultation finding this time. Here we have first sound and click, first sound and click, ejection murmur. You can appreciate that the maximum of the ejection murmur is very early in systole, so it means that the stenosis is not severe. It's certainly not calcified, because we can hear not only the click, but also the second sound. So this was another good example. Let me show you another example. This is a case with another example of aortic stenosis. Here you have again the click that is very well isolated, and then you will see and hear the murmur. So it has been built in 2 phases, only the click and the click plus the murmur. This helps you a lot to identify the click and the murmur. So it's very clear. There is a high frequency sound immediately after the first sound. But this is not the complete finding, because then you will see the ejection murmur that is, as the previous one, a rush murmur, but the apex is delayed if compared to the previous case. So this will be a severe aortic stenosis in bicuspid aortic valve. So since this, this is a case with the construction, the sound, I shall show you another time because these examples are those more useful from the teaching point of view. So please close your eyes. You will listen the click first, of course, with the first and second sound, first sound, click, and second sound, and then you will appreciate the appearance of a murmur that is systolic, ejection, rush, and delayed as a maximum intensity of the murmur. So another example, in this case, you will have no preparation of the sound, but immediately the ejection murmur. In this case, the ejection murmur is a typical one, but the maximum is delayed. And this helps you to understand that it's severe. So what I want that you do now is close your eyes and please concentrate on the maximum intensity timing. Once you have perfectly identified the systolic murmur, if you concentrate, you will listen that the murmur has a maximum that goes through the end, to the end, not immediately. To the end is immediately is. So please pay attention. This is a very simple modality. This will help you a lot, and you will understand that there is the aortic stenosis and is also severe. So please concentrate on the maximum intensity timing within systole. I hope that this has been helpful for you. So this is another example with the construction of the murmur. You will listen first and second sound, then you will listen the click, and then you will listen the murmur. At the very end, you will listen everything. But now you are more acquainted, and I think that everything will be easier. Click, 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 and now the murmur. So it has been stated that an auscultatory finding, in order to be memorized in our brain, should be heard some hundred of times, 300, 400, in order to be memorized and to be able to make an immediate comparison with sounds that are different and in this way should be differentiated. So another example, and so we are going now through the end because I want to leave time for questions. But as I mentioned, aortic stenosis is a very typical finding, and in my opinion, is one of the easiest, even if more diffuse, sounds to be recognized. The one that I'm going to show you anticipates something of the next lesson, because in the case that I'm going to present you, there is not only aortic stenosis, that is a systolic event, but also an aortic regurgitation, because sometimes the valve is both stenotic and both regurgitant. So now for the first time, I'm presenting you one of the most difficult sounds to be recognized, because the aortic regurgitation sound is diastolic, as mitral stenosis. And these are sounds that are due to relatively low gradient value. For mitral stenosis, the gradient between the left atrium and the left ventricle in diastole. For aortic regurgitation, but we shall deal with this in the second lesson, is in diastole. But the characteristic of aortic regurgitation is that it is a very high frequency sound. So here you can appreciate that you have the first sound, the ejection murmur, the second sound, and here the diastolic murmur. You will hear this diastolic murmur covering diastole, and is completely different from the murmur that you have heard so far during this lesson course. So let's go on the murmur. So I shall not go into detail of this murmur because this will be the object of the next lesson. But I wanted to emphasize in the aortic stenosis lesson that aortic stenosis cannot systematically be isolated. Aortic stenosis can be also the results of a mixed defect that is aortic stenosis and regurgitation. Here it is. Now, before the end, I'm going to show you an extremely rare auscultatory finding. So I should not say extremely rare, it's rare. In the aortic regurgitation lesson, I shall show you something that is extremely rare. What I mean for rare, the murmur we hear are usually murmur that are not considered harmonic sound. The murmur are the results of vibration of valve, vibration of liquid, but sometimes the sound seems to be a musical sound, close to what a music instrument should have produced. This is the result of the combination, casual combination in a patient of different elements, including the shape of the chest in that patient. Because in some patients, the chest configuration can be like the harmonic part of instrument, like for example, the guitar that has an harmonic box that makes the vibration of the element becoming more musical. So sometimes we hear something that remembers us music sounds. Let me show you this example. So this is a aortic stenosis with a musical impression. As you will notice, there is no filtering in this case of the electronic apparatus, and this is a real auscultation with the sounds and the noise of a room, because nothing has been filtered in order to maximize the musical part. So this has no specific meaning. It's only the results of natural transformation of sounds in musical sounds due to the fact that in that patient, the thorax is working like a musical instrument. Let's listen again, because this is not a common finding. In the diastolic regurgitation, I shall show you something that is extremely rare. So it's nice. So before concluding, let me show you, as I told you, two examples that I shall show consecutively. in order to give you the possibility to appreciate the difference of two very important systolic murmur, aortic stenosis and mitral regurgitation. I shall show you one immediately after the other so that you can be concentrated. I shall not make comments in order to avoid any kind of disturbance or time lost. I shall show you one and the other, and I'm sure that if you are concentrated, you will appreciate the huge difference between two important systolic murmur, one the aortic stenosis and the other one the mitral regurgitation. So I'm going to start. You will hear aortic stenosis first and mitral regurgitation immediately afterwards. So these were two consecutive sounds, two consecutive auscultatory findings. The first one was aortic stenosis, systolic and rash. And the second one was mitral regurgitation, systolic and soft. So I should stop here, Dr. Rennan, and I'm ready to interact with you and with our colleagues in case there are questions that needs to be answered.
All right. Thank you, Professor. It's very interesting lecture, and then there are lots of question about that. So we will start about this question related to your last examples, in which the hard sound of aortic stenosis and mitral regurgitation. So how is the question? How to differentiate bicuspid aortic sorry. How to differentiate between what is bicuspid aortic valve and mitral valve prolapse? What and what if there are simultaneously present at the one patient, for example?
So sorry, can you repeat the question?
Yeah, how to differentiate bicuspid aortic valve with mitral valve prolapse?
Okay.
Mitral regurgitation. That's first question. So please answer that.
Okay, so I think that the colleague is concentrated on the fact that in both diseases there is a systolic click.
Yeah, yeah.
And are the two only possibility to hear a systolic click. We have no other possibility, with the exception of the so-called non-cardiac clicks that can be produced by chest deformity or things like that. But apart from these things, yes, in both situations, there is a click. The big difference is that in bicuspid valve, the click is immediately after the first component of the first sound. So it is something that is attached to the first sound, cannot be delayed, because the first sound is made of two components that are, number one, low frequency sound due to the closure of the mitral valve, and then high frequency sound never heard in normal people that is due to the opening of the valve. So if we, let's say, if I return to a slide that I've presented, so let me allow it to return to this one. This will be helpful because let me show. Okay. If we go here, you will see that this is the first sound because of the closure of the mitral valve, and this is the ejection click because of the opening of the aortic valve. When you have a non-ejection click, that is the mitral valve prolapse, is usually positioned either in mid-systole or in late systole. So the answer to the question is the differentiation between the two is the positioning of the click within the cardiac cycle. Very early for the bicuspid, relatively late for the mitral valve prolapse.
Yeah. Okay. This also answered the question. A similar question appear here. How can we differentiate between the finding of irradiation of bicuspid aortic valve in mitral area and the mitral valve prolapse? It's clear the answer is the timing of the click is different. So this also question from my colleague, Dr. Zainuddin Khan. He's a cardiologist. Dear professor, how we do differentiate between aortic stenosis with hypertrophic obstructive cardiomyopathy, especially, for example, those with SAM, systolic anti-anterior motion?
The answer is it's very difficult. It's not an easy differentiation because the pattern is not dissimilar. The only thing that can help us to differentiate two situations that are one very close to the other. This is a very good question because it comes from someone that is experienced, because this is a differential diagnosis that is not rare. The only possibility is when the hypertrophic obstructive cardiomyopathy is accompanied by mitral regurgitation due to the distortion of the valve caused by the SAM. In that instance, two murmurs will coexist. One is the ejection of the obstruction, the other one is the mitral regurgitation of the distortion. And the two murmurs will have the same timing. And usually, but I mean usually, what happens is the quality of the sound, the type of the sound, change moving from the mesocardium to the apex. And so the two components that are coexisting can be appreciated being at the same time. But again, this is difficult. The other things that can help us in make a clinical diagnosis, the electrocardiogram, that if the hypertrophic cardiomyopathy is present, sometimes has some aspects more typical of the cardiomyopathy, like the Q wave, giant alteration of the ST-T repolarization. But again, it's a difficult distinction by auscultation.
But if you want to differentiate between isolated aortic stenosis and isolated hypertrophic HOCM, can we rely on the presence of click?
Mm.
But we rarely have click in HOCM, right?
If we here, of course, we are speaking about not all people, because usually what happens is that if we have a bicuspid aortic valve, before or late, these will become calcified. But if we have a patient of 40, 50 years, the aortic stenosis due to bicuspid valve can be present, the hypertrophic cardiomyopathy with obstruction present. In that instance, the presence of the click give you no doubt, because there is no reason to have a click in obstructive cardiomyopathy. If the click is present in ejection click followed by murmur, the diagnosis of bicuspid aortic valve is
bicuspid,
cannot be something else.
If there is this caused by bicuspid. What if to distinguish, as mentioned, by there a possibility that would have second heart sound? If the second heart sound is slightly decreased in frequency, then we or the intensity, then that would be severe aortic stenosis that would not be present at the
hypertrophic cardiomyopathy. That's, of course, is another good modality with you, because there is no reason to have a reduction of hypertrophic cardiomyopathy of second sound. But again, if the differential diagnosis is between bicuspid and obstructive cardiomyopathy, there is no reason to have a reduction of the second sound in a bicuspid valve with the click, because it means that the valve is still good. But I agree with you, the second sound intensity is another modality especially in the old people.
Okay. Okay,
Also,
we move.
by the way, sorry.
Yeah, okay.
Sometimes the two things can coexist.
Oh,
You can
really?
have
Yeah,
aortic stenosis and hypertrophic cardiomyopathy,
yeah.
and then it becomes a serious problem from the treatment point of view, because if the aortic stenosis is important, one thing to eliminate, to substitute the valve, is to consider that if someone substitute the valve in aortic stenosis with important obstruction due to a coexisting hypertrophic cardiomyopathy, in this way, you will increase the obstruction, because you are reducing the afterload, and this will increase contractility of the left ventricle and even further obstruction. So these are difficult cases, not only for the diagnosis, but also for the decision for the treatment.
Yeah, that's combination is more. I found quite frequent. Even some of my patients, we really hard to find whether the pressure gradient coming between because of the HOCM or because of really coming from the aortic stenosis. So we need to do many echo modalities to distinguish. So we move to another question from our colleagues. Dr. Mike, okay, Dr. Tony Paringon, did you answer this question? Why does the aortic ejection murmur radiates to the apex?
Sorry, can you repeat?
Yeah. It's number 3. Maybe you can see that. Why does the aortic ejection murmur heard or radiates to the apex?
This is okay. This is from Tony.
Yeah, Tony.
So this is a very good question. It's not rare, and in my opinion, because these are things that are observed and are the results of the comments are the results of experience, because there are no scientific paper taking care about this. But the experience is good like a scientific paper. So my opinion is the following, and the irradiation from the aortic area to the apex can be the results of two components. One is the chest shape. The other one is the, the shape of the heart, because I have no picture in front of me, but let's suppose that we have just 1 second. Let me try to do something very simple. So this is what we usually see in the left ventricle, and we have the aortic valve and here the septum. Sometimes in some people, so the experience show that the combination is not exactly in this way, but is in this way. And there is like a curve, so that the septum is not exactly aligned in this way. When there is a curve such as this one, what happens, in my opinion, is that not only you have the jet here, but also you have a turbulence here. So you have a turbulence that is much longer because of the curve existing between the interventricular septum and the aortic valve, and this will create an irradiation. So what I do with my students is that when I hear something like that, so the rule number 1 that I follow when I teach to my fellows is that we make auscultation, and then we go to see the echocardiogram, and we try to predict from what we hear what we shall see, never the opposite. And what is relatively common in these cases, as the one that Tony has described, is that there is this kind of curve. And this explains why there is larger auscultatory finding that is simply due to the fact that the turbulence is longer because it's not only located through the valve, but also in the outflow tract.
Yeah, that's a variation of anatomy of different patient, of different people. So
Yeah.
that's all. I remember your interesting musical sound that you saw. Is that because of this some kind of that variation in your patient, especially those with interesting sound that you saw, musical one?
You are going close to the true, but I shall show you during the aortic regurgitation.
Okay, okay.
This is the surprise. This is the surprise.
Okay.
This is the surprise. So
Okay.
you have already the answer, but please don't tell it. Don't tell anything.
Yeah,
I
yeah,
know
okay.
you have the answer, but
But
don't tell
everybody heard
anything.
you.
Okay, promise
Okay.
me.
Okay. Dr. Michael asked you, why is the click in bicuspid aortic valve best heard not in the upper right, right, not in the upper right sternal border? See the question from Michael.
Yeah. So the click, in my opinion, okay, the click is always systematically better heard in the mesocardium.
Mesocardium.
Mesocardium. And better heard with the diaphragm, better heard if the diaphragm is pressed on the skin. Is not irradiated to the apex, in my opinion, because the irradiation of sounds or murmur is the results of the direction of turbulence. So the aortic stenosis irradiated through the aortic area because the flow of the murmur is in that direction, and the vibration is through the aortic root and aortic root and ascending aorta. But when there is a sound that is related to a very local situation, very local situation, that is the opening of the valve, there is no reason to be irradiated unless the intensity of the sound is so strong that you can hear somewhere else. So we have to make a distinction between sounds that are heard not only in the specific place, uh, because this can occur for two reasons, either because the sound is very strong as intensity, or because the irradiation is caused by the turbulence and the flow that goes in a direction. Last time I showed you the irradiation example of eccentric jet in mitral regurgitation. So if the jet is through the posterior wall of the left atrium, then the radiation will be through the axilla. If the jet is through the posterior part of the aorta, as in leaflet, flay leaflet of the posterior wall, the posterior leaflet of the mitral valve, then the radiation will be through the aorta. So the answer is there is no reason to be irradiated because there is no flow, no turbulence, but it's just opening.
Yes. I think that's, yeah, I think that's clear explanation. Let's move to the question to Dr. Maria Elviana. She has difficulties to recognize the murmur is either systolic or diastolic murmur because there has a click after S1 without seeing your phonograph. So it's heard as diastolic murmur. Could you please to remind us how to know the click in S1 is not referred to S2? So again, this is yeah.
Okay, so okay, I'm reading the question.
Yeah, from Maria, Dr.
Uh,
Maria.
okay. No, this is a good question. Okay, let's suppose that we have no murmur and we have only the click of bicuspid valve. So Maria says it could be confused with the splitting of the second sound. And how can we say that this first sound and not
Or
second sound. And of course, the murmur that follows will be systolic or diastolic according to the interpretation of the click. So I think, Maria, that there are different aspects that when you make auscultation, you have to consider. So first, the splitting of the second sound can be only heard on the pulmonic area. So if you hear this splitting, let's call splitting, on the apex or mesocardium, as it happens for bicuspid valve, it cannot be splitting of the second sound because, as I told as I told to the previous um, question, the irradiation does not occur for click, it occurs for murmur. So the first rule is where you are listening. Second, if the splitting first sound that could be theoretically confused by splitting second sound is followed by murmur, the kind of murmur is dramatically different because the systolic murmur has always a high intensity, is ejection. It cannot be confused by the aortic regurgitation murmur. We shall listen aortic regurgitation murmur in the next lesson, and it will be clear to you why it cannot be confusion between the two. And in any case, don't forget that the place where you are collecting the sound is important for the differential diagnosis.
yeah, and Dr. Maria, as shown by Professor Riseto before, that the intensity of clicks is high pitch, high intensity compared to the hard sound S1 or S2. So this is another question, Professor Riseto. In the beginning of next session, is it possible to share a little bit about the murmur of Hockham compared to the aortic stenosis? Do you have the
Okay.
that next session maybe?
This will occur in the next lesson.
Okay.
Next week. Next
Okay.
week there is hypertrophic cardiomyopathy, and okay, I should put also aortic stenosis close
Stenosis,
to
yeah.
cardiomyopathy. But next time there will be a miscellaneous various finding that
Yeah.
will be patent ductus arteriosus, tricuspid regurgitation, pulmonic
Yeah.
stenosis, hypertrophic cardiomyopathy, and okay, no, it's already foreseen. This will occur.
Okay. So my colleagues will have many interesting case next this session and next session, in which frequently we find our practice in which more one or two disease present simultaneously. So this is a question from Dr. Yol Purnama. He's in Bahasa Indonesia. He's a GP, Professor Liseto. He has a patient 65 years old with the heart sound like sound of radio, with when you try to search a frequency like that with very high pitch. Is that because of natural transformation of the heart sound? That possible?
Okay, I think that what Yoel Purnama has heard is something that we shall discuss, and is very likely what is commonly called honk.
Honk. Oh, yeah.
Honk.
Enki. Oh, yeah.
Honk is a very strong musical sound, like the one that is heard with birds. So it's very musical, very strong, and sometimes the patient says that they hear this sound. So if is what I'm thinking, this sound, the honk, when there is a honk, usually happens that moving the patient, moving the chest, making some kinds of torsion, that the honk can either increase or disappear. So what produce honk? Because what you have described as with the sound is woo, 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 something like that.
Yeah.
It's produced by vibration. So it's the combination of But I'm anticipating something that I have to tell in the next lesson. In the next lesson, we should speak about something like that. I don't want to tell
Okay.
anything to you. Is part of the surprise. Okay, no, I
Yeah,
don't
yeah.
anything. Let's discuss
Okay.
after.
Yeah.
So you keep in touch with us,
Yeah.
because then because I want to know from Joel if what I should show you is what is hearing.
Yeah.
So you be with us.
Yeah.
We
The
need to
doctor.
know.
Yeah.
Yeah.
Dr. Yol said that the sounds like the sound that we usually heard when you try to search a frequency in the radio, Cheet, or like that. Cheet.
But I shall show a sound.
Okay.
Lesson.
Okay.
Joel is to tell us if it's close to that or not. And then
Okay.
something that I want to know from Joel, because I've seen that Joel is writing not in English, so I'm not
Yeah.
have identify his Joel Purnama. I want to know from Joel Purnama if
Yeah.
the patient is capable to hear the sound on himself.
Yeah.
So,
Okay.
let's return on this case, Joel. Is the last recording of my next lesson. And please let me know through Dr. Renan if the patient, two questions. First, if the patient hear this sound himself. Secondly, when you hear, visit the patient, if moving the chest, something change or not.
Yeah. Okay. So you will have like example like that, right? Yeah.
Yeah, I hope
like
that is exactly what he wants, but I have something interesting to share.
Okay. Can we move to the next question?
Okay, so let's start. Okay, let me.
No. There's another question.
Okay, fine.
Okay. This is coming from. I have to show you because this is from Dr. Aryaska Ansunarta, is our senior doctor here. He's an expert in echocardiography. Dr. Aryaska said that the stenotic murmur as going along of aortic stenosis, going along the carotids, hasn't any relation with the degree of severity or type of aortic stenosis?
So the irradiation of the murmur to the carotid.
Yes.
I think that is more the expression of turbulence going up than the severity. The severity is better expressed by the timing of the peak of the jet. And we have to consider two things. I didn't mention what I'm going to tell because I didn't want to create confusion. But the peak of the jet is extremely useful because when it's late, it means that there is a severe stenosis. If it's early, there are two possibilities. The first one is that it's not severe. The second possibility is that it is so severe that there is also left ventricular dysfunction. And if there is a severe aortic stenosis and left ventricular dysfunction, the murmur becomes lower as in intensity because there is less turbulence, because there is poor contraction, and the maximum of the ejection is reached very early in systole because there is not enough power to have ejection phase long. So the timing is that is the most important element to make a good estimation of the severity.
So that's also maybe interfere with the LV function as mentioned, the presence of low gradient aortic stenosis, right?
Yeah.
Low gradient AS. Okay, we see the last, I don't think last question. Dear Professor, regarding distinguishing isolated HOCM and isolated aortic stenosis, can we use maneuver such as Valsalva or squatting? Any different in frequency, perhaps? It's a good question.
No, this is a very good question. We shall face this question next week when we shall face hypertrophic cardiomyopathy. But I can anticipate that he is right because some of these maneuver can enhance the obstruction level and therefore to enhance the auscultatory finding.
Yeah, I think that's all of the question. So you need time to.
Okay, so let's make a 5 minute stop. I drink a little
Yeah.
bit of water, but
Okay.
really 3-4 minutes, and
Yeah.
we should start with the test, and then we shall move to artery regurgitation, and
Okay.
the
Okay.
last finding will be the surprise. Okay.
Okay. Okay.
Okay.
Keep. Stay with us, everybody. I will
Okay.
have
So
5 minutes.
I
Five
switch off
minutes.
the video because I charge my computer
Okay.
in these few minutes. Okay.
Okay. I'll see. I'll see you in 5 minutes. Okay. See you,
In
Professor.
a very short
Okay.
while. Okay.
Okay. Professor Iliseto, are you ready?
Yes, 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 ready. Okay, so let's
Okay.
start with the test
Please.
number 2, as usual. So we have, okay, 2 tests. Let me show you, as usual. Okay, okay, okay. Okay, so the first test is difficult. So not easy. I am aware. So let's move to the list of possibility, and here we have. So is pericardiosis, a mixture of aortic stenosis and regurgitation on, I don't know, 5, 4, 3, 2, 1. Okay, so this is what is being collected. Most of the people thinks that this is aortic stenosis and regurgitation. So let me show you where the truth is. Moving to the okay, so this is the recording, and is a recording that covers both systole and diastole. So this is without filtering, of course, because it has to be emphasized. So you have first sound, second sounds, and the murmur, the sounds cover everything. And I think that this is the reason why most of the people told to aortic stenosis and regurgitation, because they cover both systole and diastole. However, this is what is commonly called a continuous murmur. Continuous murmur is the murmur that is produced by fistole, for example, in which you hear the flow that is continually running, and this produce, of course, these disturbances. So this is a patent ductal arteriosus. Let me show you. It's a continuous murmur. So the next test is another case. Okay, let me show you the auscultation funding. Let we shall vote. So let's go to voting. It could be mitral regurgitation, mitral stenosis, aortic stenosis. And here is the pooling of the vote. 5, 4, 3, 2, 1. So the majority was for mitral regurgitation. Let's go now on the test. And okay, and here is the recording. So you're correct, is mitral regurgitation. And Dr. Renner, I want to emphasize that this test was made on day number 1, and the success rate today is double, more than
Oh,
double.
no,
And
great.
so I'm very happy about that. Very, very, very
Yes,
happy.
great, great.
Okay, good, good. So let's move to the aortic regurgitation. Please allow me to close one file and to open the appropriate file. Here we are. Okay, aortic regurgitation. So this slide summarizes, as usual, as I prefer to do each time that I have to present a murmur, the hemodynamic basis of the murmur. So aortic regurgitation occurs in diastole, this gray area, because in diastole, the aortic valve is not competent. There is regurgitation because it does not work properly. And because of this, there is a gradient between the aortic root and the left ventricle. And this gradient starts immediately after closure, closure of the aortic valve. So this gradient is affected by the two pressures. One pressure goes down, is the aortic one pressure goes up, is the left ventricular one. So depending on the status of these two pressure, the murmur can be long or short. So from this graphic, it's clear that if the pressure goes rapidly down because regurgitation is severe, and the left ventricle goes rapidly up because the left diastolic pressure goes up because of the importance of the regurgitation, if something like this occur, then the murmur is not long as the entire diastole, is shorter. So the length of the murmur in aortic regurgitation can be inversely related to the severity of the regurgitation. The other aspect that is to be considered is that the sound is high frequency sound, very, very high frequency sound, but the intensity is never so strong as we should like because it's not an ejection murmur. Ejection murmur are stronger because are due to the contractility of the left ventricle, mitral regurgitation, aortic stenosis. These are gradient in passive condition, as are those present in diastole. This is a diastolic two-dimensional echocardiography in a patient with aortic regurgitation. And what we observe if there is color Doppler is that an important jet occurs. Sometimes the jet can be through the mitral valve instead of being in the outflow tract. When something like this occurs, as in this enlarged vision, it happens that the anterior mitral leaflets cannot open completely. And if something like this occurs, is not unlikely that a sort of secondary mitral stenosis due to the fact that the valve cannot open can develop. This relatively mitral stenosis can produce a murmur that is identical to the aortic stenosis one, and is the so-called Austin Flint, is a murmur caused by relatively mitral stenosis. This is what we can observe in diastole with color Doppler. This is the turbulence, and I show you this in this M mode. This is the M mode of this patient, because this gives an idea of the length in diastole of the murmur. And this is what is commonly seen in M mode echocardiography. And as you can see, here you have a flattering of the valve. But what is important is the valve closure is rapidly developing before the normal systolic, here it is, event, it opens. This is likely due to the high pressure in the left ventricle. Here it closed and then it reopened during atrial systole. So aortic regurgitation is due to a passive gradient that is influenced by two pressures, and the combination of the two pressure represent the basis of the pressure development. This picture highlights the classical maneuver that has to be done to emphasize the presence of a high frequency sound of matter regurgitation. As you can see, this doctor is using the diaphragm, is pressing the diaphragm on the skin because it reduces the distance between the heart and the auscultation area of the stethoscope. And the best situation is to put the patient in a sitting position in complete expiration with the chest put toward anterior position. All these maneuver, pressing, diaphragm, expiration, sitting, flex anteriorly, will enhance the distance, the reduction of the distance between the diaphragm and the source of the murmur. So these are things that are important because otherwise the diastolic murmur of aortic regurgitation can be easily lost. Aortic regurgitation murmur is better heard on C area, and this is the area of best auscultation for aortic regurgitation. Sometimes the irradiation is through E, and when something like this occurs, it means that aortic regurgitation is present in a huge ascending aorta dilatation, because in that situation, the murmur will irradiate through the right border because of the large aortic root. So let's start now with the auscultation finding. And this is an example of aortic regurgitation. And as usually, as I like to do with you at the beginning of each lesson, we shall have 3 consecutive beats without murmur, and then the murmur will appear. So please watch and listen, and then you will listen with the closing eyes. So I think that you have appreciated a murmur that is completely different from the one I showed you before. Please listen, sorry, please listen with your eyes closed. And I want to underline and emphasize the fact that this is a high frequency sound with relatively low intensity and could be easily missed. But that's the reason why some maneuver have to be performed. Close your eyes and please listen with attention. So another case with the typical aortic regurgitation murmur. Okay, I hope that this was clear. But what I want to show you now is something different. Sometimes in aortic regurgitation, apart from the diastolic murmur, a systolic murmur can be heard. There are 2 possibilities. One is that a coexisting aortic stenosis is present, and I showed you before, but more frequently, the presence of the murmur is named accompanying murmur. So a murmur that is not the result of aortic stenosis, but is the result of increased flow through the aortic valve during ejection caused by the larger amount of blood entering the aorta that is made by the normal blood plus the regurgitant volume. In that situation, the systolic murmur is named accompanying murmur. Then we have to learn how to differentiate a systolic murmur that is due to aortic stenosis to a systolic murmur that is due to accompanying situation. What I'm going to show you is an accompanying situation. Usually, the accompanying murmur, here it is a murmur that is very soft, short, with a maximum of ejection relatively early because there is no gradient. And now in this case, you can hear very well the regurgitant murmur, and you can hear this soft, low intensity ejection murmur that is due to the fact that the amount of murmur, of blood that is going through the valve is increased. This is a case in which, as you can see, the murmur is heard not only in C, but also in E, in I, sorry. And as I mentioned, when something like this occurs, it means that there is dilatation of the aortic root. Here it is this murmur that is also heard on the right sternal border. Okay, sorry, I repeat the murmur. So this murmur, in this patient, two things are important. The first one is that the murmur is irradiated on the other side of the sternal border, on the right side. And the other aspect that is important is that the murmur, the systolic murmur, is accompanied by soft ejection, low intensity murmur that is an accompanying murmur. So this is not a rare situation, the situation of the accompanying murmur. This is now a construction of three different phases. You have normal beats without murmur, then you will have the accompanying murmur, and then the aortic regurgitation. So I want to emphasize the fact that aortic regurgitation can be accompanied by murmur, but that murmur does not imply the presence of aortic stenosis. I shall show you in a while two examples, one close to the other, as I did before for aortic stenosis mitral regurgitation, to emphasize the difference in systolic murmur when there is stenosis or not, when there is a accompanying situation or not. So let's go ahead with the auscultation of this example. Please watch the screen first, and then let's listen again with closed eyes. Now I want that you listen again, closing your eyes, because you have to be aware about the fact that we have normal beats without the murmur, then a murmur appears, and this is an accompanying murmur, and then the aortic regurgitation murmur will appear. So, summarizing, aortic regurgitation is a diastolic murmur, is a high frequency murmur. is high frequency but low intensity murmur. Because it's low intensity, some maneuver needs to be done in order to emphasize. The maneuver is different from the mitral stenosis 1 that are usually characterized by the fact that the patient is asked to lying on his left side, or to make a short exercise in order to emphasize flow through the mitral valve, and because of this gradient and because of this auscultation finding. In this instance, it can be emphasized just putting the patient in a sitting position with the anterior movement of the thorax. So I explain you also that there are two possibilities of systolic murmur, either accompany, either real stenosis. Now I shall show you two consecutive examples. The first one will be, let me prepare, will be this one, in which the, sorry, in which the murmur is an accompanying murmur, and immediately afterwards an ejection murmur that is the results of aortic stenosis. You can notice that in the first case, the murmur is very with a peak very early. In the second one, it will be late. You also appreciate that the intensity will be different. But let's go to the auscultation first. I shall show you the two cases without comments. So I shall show you again. Please ignore the diastolic murmur, the high frequency murmur, the regurgitation, and concentrate on the systolic. If you concentrate on the systolic, you will see that the first one is relatively soft if compared to the second one that is relatively hard and rush. So let's listen this first. Please concentrate on the systolic phase. And now on this one. So the characteristics of the murmur will help you to understand exactly what you have in front of you. And now, before concluding, I want to show you the last example that is extremely rare. I show you also the recording that is strange. Look at it, is different from the other that I show you. Is more uniform. This is a musical sound, because the sounds that we record are very irregular in shape. And this is exactly what we can record if you use phonocardiography, for example, with a guitar. So let's listen this sound, and then I tell you what there is behind. Let me show you again. Okay, let me check something. I want to be sure that, okay, I show you this again with a slight modification of the sound expression, because I want to listen perfectly. So this is a diastolic murmur in a patient with aortic regurgitation. And the aortic regurgitation was due to a flay leaflet of the semineural valve. And what is producing this strange sound, musical sound, is the combination of the fluctuation of this leaflet that is like the corda of a guitar that fluctuates, and very likely the thorax shape in that specific patient that cannot be predicted, that transform this vibration from a sound in a musical effect. So this is what can be called a honk. Honk are more frequently systolic, and one of the more frequent honk situation is the presence, for example, of flay leaflet in the mitral valve prolapse. Some patients with Marfan syndrome can have important huge prolapse and leaflet, and this can vibrate, and in some instance, in rare case, the thorax shape can act as harmonic component of the instrument. So this is the case that I want to show you, and I'm curious to know if the sound that was heard in the patient of our colleague was similar to this one or not. But I have to find among my cases a systolic onc that I shall show you in the last lesson. So Dr. Renan, I'm ready to answer question.
All right. Thank you, Professor Liseto. So we start with the question from Dr. Bima, Ahmad Bima Arya Putra. Good day, Professor. I would like to ask how to differentiate between Austin Flynn murmur in aortic regurgitation and mitral stenosis, and what will we found if these two diseases coexist?
The murmur in of the relative stenosis of the mitral valve in the of our mitral stenosis. The only thing that in Austin Flynn usually is not present is the opening snap, because in mitral stenosis we have not to forget that we have the following component. First is the opening of the valve, and this produces the opening snap. Then we have to use the opening and the rumble, the flow that produce the murmur. And then we have the presystolic murmur, the reinforcement of the rumble presystolic. The rumble and the presystolic reinforce are present in the Austin Flynn. Usually the opening snap not, because the valve is a pliable, is a good valve, while in mitral stenosis is a rigid valve, then when opens, create a sound.
Yeah. Okay. This is another question about how to distinguish between acute AR and chronic AR instead of other clinical parameters such as clinical severity, rails, etc. Can you differentiate acute AR and chronic AR?
The only
As for Gallup, yeah.
no, this is of course a very important question. So the only auscultatory finding that can help us, but not tell us 100% certainty that is acute, is the length of the regurgitation. Usually, usually in the acute regurgitation, the murmur is short because there is a boom, a rapid elevation of endostolic pressure. This will reduce the gradient in late diastole, and because of this, we shall have a relatively strong murmur very early, and then it disappears because it does not cover diastole, but it does not cover diastole because the endostolic pressure being sudden and important, the aortic regurgitation goes up the pressure because there is not enough time to adapt the left ventricle of the increasing volume. So if there is aortic regurgitation, acute aortic regurgitation in a normal ventricle, the left ventricle will require time to adapt, to enlarge, to be more compliant. But this will produce elevation of pressure, and this will produce reduction of the length of the diastolic murmur. So the only element that we have is the length of diastolic murmur, the duration.
The duration. So the longer the duration, probably the more chronic the disease, right?
Absolutely, yes.
Okay, this is there are two related questions about the Austin-Flynn murmur. So can you please explain what is the cause of Austin-Flynn murmur, and how can we detect both the mid-diastolic and presystolic murmur in Austin-Flynn murmur? Okay.
No, please go ahead.
And this the related question. He or she read that Austin-Flynn murmur can be happens in any valve, even its aortic regurgitation. He read somewhere. So what's your explanation for these two questions?
So aortic regurgitation not systematically produce Austin-Flynn. It can produce Austin-Flynn when the jet is eccentric. And that's the reason why if you hear Austin-Flynn, we can predict the direction of the jet. The direction of the jet goes to the anterior leaflet of the mitral valve. So when something like this occurs, we have this relative reduction of the opening, and because of this, we have a relative stenosis. So this is the only situation in which a relatively aortic mitral stenosis can be produced. By the way, there is another situation in which a murmur of mitral stenosis can be heard without the presence of mitral stenosis. And this is the presence, for example, of left atrial myxoma. Because the myxoma goes into the valve, it creates a relative stenosis. So we have two situations that are completely different, but that produce mitral stenosis in a very good valve. When the jet closed the valve, or when the valve, the aortic jet closed the valve, or when the valve opened quite well, but a mass impede complete flow through the valve. These two examples are the extreme, but they both explain the origin of the murmur. The origin of the murmur is the discrepancy between the orifice and the flow that has to pass through the orifice. In Austin-Flynn, because it's closed from outside. In myxoma, because it's closed from inside.
Okay. This is another question from Dr. Pierre Octavian. I try to figure out what he means. Hello, Professor. In a company murmur in aortic regurgitation that contain diastolic plus systolic murmur, it can happen just in tachycardia condition?
Yeah, tachycardia can enhance
these
as all the tachycardic situation in which a flow murmur can be heard because there is faster ejection. So yes, it can enhance the situation, yes.
And again, continuing this question, is there any relation between the severity of the aortic regurgitation and the presence of the accompanying murmur, Professor?
Theoretically, yes, and I should say that it works as a concept because the accompanying murmur is the results of discrepancy between the flow through the orifice and the entity of the orifice. So the orifice is normal and the flow is increased. This will create a turbulence. But the extreme could be that there is a huge regurgitation due to dilatation of the annulus because of aneurysm, for example. But in that instance, the accompanying murmur will either disappear or not develop at all because there will be increasing flow through an increased orifice. So the accompany is the expression of discrepancy between the amount of flow and the orifice size. If the orifice size is enlarged, then the flow will be coherent with the size, and the accompanying murmur will not be present.
Okay, thank you. So it's not a question about, yeah, this is interesting about the Hong sound one. Thank you for your explanation. In my case, it's hard. Oh, sorry. This is about. I'd like to clarify. So cardiac honk is basically a normal murmur, but sounding musical because of the variation in the patient's chest and a specific variation in the shape of the valve. Was that true, Professor?
So the honk is a very, very rare that the honk could be present in a normal subject, because in any case is the result of something that does not work well. What can be found, and I think that in my experience, I have only one case, if I remember well, many years ago, was a young female with a very small prolapse, but mitral valve prolapse, but the vibration in systole of the valve with the small leaflet vibrating produce this kind of murmur. So honk is the result of abnormal vibration of something, and is unlikely that the honk vibration can occur in a normal valve, but is not the expression of a severity. I agree, is not the expression of severity. It's just a casual combination of different aspects that will create a musical sound.
Okay. Then I think the last question is whether you have to, as you know, when we try to hear the mitral regurgitation murmur, then you should manipulate the position of your stethoscope going to the axilla, right? So to see where's the punctum maximum of the murmur. So should you do some kind of maneuver for the aortic regurgitation, given the fact that the direction of the jet of the AR also can be any different side, any different direction?
We can do with aortic regurgitation maneuver to emphasize the entity, the intensity, and because of this, better hear the murmur. But usually what happens is that the maneuver do not affect irradiation.
Okay.
And the aortic murmur irradiation, the aortic regurgitation irradiation is usually either through the right sternal border when the aorta is extremely large, or through the apex. This is important when the jet goes through the mitral valve. And in this instance, the Austin Flint can occur. And see you next week at the usual time.